In clinical practice, it is important to use tests that can accurately evaluate patients. Diagnostic accuracy studies help us figure out how accurate these tests are, so we can make good decisions. In this video, we will show you how to appraise diagnostic accuracy studies, so you can judge their quality and usefulness. Diagnostic accuracy is all about how well a test can tell if someone has a specific condition or not. In a diagnostic accuracy study, 4 aspects need to be assessed: patient selection, index test, reference standard, and flow and timing. Patient selection refers to how participants are chosen for the study. It involves deciding who can be included based on specific criteria, such as age, symptoms, or other relevant factors. Index test. The index test is the particular test or examination being studied. It is the test that is used to diagnose or identify the condition of interest. Reference standard. The reference standard is the benchmark or gold standard against which the index test's accuracy is compared. It is a widely accepted or established method or test that is considered the most reliable for diagnosing the condition. Flow and timing. Flow and timing involve the sequence and timing of performing the index test and the reference standard in the study. It examines how the tests are conducted and the order in which they are performed to ensure accurate results. We will use questions to help us assess each of the 4 aspects. Each question has 3 possible answers: yes, no, or unclear. When we answer yes, it means that aspect of the study has a low risk of bias. If we answer no, it suggests there might be a high risk of bias, so we need to be careful when interpreting the study. When we answer unclear, it means we do not have enough information to give a definite answer. The first aspect is patient selection. This refers to how participants are chosen for the study. It involves deciding who can be included based on specific criteria, such as age, symptoms, or other relevant factors. Question 1. Was a consecutive or random sample of patients enrolled? Random sampling is a method used to select participants in a way that gives everyone in the target population an equal chance of being chosen. It's like picking names out of a hat. By using random sampling, researchers can obtain a representative sample that reflects the characteristics of the larger population. Consecutive sampling is a method of selecting participants in which all eligible individuals who meet certain criteria are included one after another as they become available. A diagnostic accuracy study should ideally enroll all consecutive or a random sample of eligible participants with suspected disease. This approach minimizes potential biases that may occur if patients are selectively included or excluded based on certain characteristics. Let's consider a study evaluating a diagnostic test for detecting cervical radiculopathy. The researchers are comparing the accuracy of the new test with an existing reference standard, MRI. Scenario 1. Consecutive or random patient enrollment. In this scenario, the researchers include patients one after another as they come in, or select them randomly without picking and choosing based on specific characteristics like age or gender. They include anyone who has symptoms of cervical radiculopathy, such as neck and arm pain, and meets the study's requirements, such as no contradiction to MRI. By doing this, the study includes a diverse range of patients, making the findings more reliable and applicable to others with similar symptoms. Scenario 2. Selective patient enrollment, such as convenience sampling. In this scenario, the researchers choose patients based on specific characteristics or convenience. They might exclude patients with certain conditions, severe symptoms, or those who have already had a different diagnostic test. This selective approach might make the study easier to conduct, but it can introduce bias. The excluded patients could have different experiences or responses to the diagnostic test, making the study's results less accurate. This means the findings may not represent the larger group of people with suspected cervical radiculopathy. It's important to include a diverse range of patients to get a more reliable understanding of the condition. Question 2. Was a case control design avoided? In diagnostic accuracy studies, cohort or cross-sectional studies are preferred to allow consecutive or random sampling of patients. A cohort study is a preferred study design for evaluating diagnostic accuracy. A group of people who might have the target condition is included. All of them get a test, which is the index test, and the trusted comparison test, which is the reference standard. By comparing the results of these tests, researchers can figure out how well the diagnostic test works. The cohort design gives estimates of accuracy, like sensitivity and specificity, right from the data they collected. In a cross-sectional study, researchers test one group of people with both the index test and the reference test at the same time. They look at the results and compare them to see how well the index test matches up with the reference test. By doing this, they can figure out the accuracy, like sensitivity and specificity of the index test. Why avoid a case control design? In this design, participants are chosen based on whether they have the condition being studied as cases or not as controls, and then they are tested with the index test. Consecutive or random sampling is not used. This selective approach can lead to biased estimates of diagnostic accuracy, while the results of the case control design can help to plan for more advanced cohort or cross-sectional studies. They cannot be directly applied to clinical practice. Question 3. Did the study avoid inappropriate exclusions? In a diagnostic study, excluding certain groups of patients can make it harder to know how well a test works in real-life situations. Patients have different symptoms and unit levels, so excluding them can make the test's accuracy seem better or worse than it actually is. For example, it's inappropriate to exclude patients with conditions like diabetes or high blood pressure for no good reason. These conditions are common and can affect how a condition shows up and gets diagnosed. It's important that the study explains why they excluded certain patients so we can understand how it might affect the results. Sometimes they exclude patients who clearly have the condition, which might underestimate the test's ability to detect it overall. On the other hand, if they leave out patients who are harder to diagnose, it might make the test's accuracy seem better than it really is. Those challenging cases are important to study because they show how well the test works when things are not clear. Including a diverse group of patients helps us know if the test can accurately identify the condition in different situations. Index test. The second aspect is the index test. The index test is the particular test or examination being studied. It is the test that is used to diagnose or identify the condition of interest. Question 1. Were the index test results interpreted without knowledge of the results of the reference standard? Blinding or masking of the interpreters is important to avoid bias in a diagnostic study. When interpreters of the results know the reference standard results, they can affect how they interpret the test. This can make the test accuracy seem better or worse than it actually is. By blinding the interpreters, we make sure their judgment are fair and not influenced by what they know about the reference standard results. The potential for bias comes from how the tests are interpreted and the order they are done in. If the test is always done and interpreted before the reference standard, that is a good thing, and this question can be answered yes. It means the test's interpretation is independent of the reference standard results. Alternatively, if the test is done and interpreted after the reference standard, it can still be answered yes if the person doing the test doesn't know the reference standard results, which means they are blinded, or if the test is an objective one that doesn't rely on personal judgment. Question 2. If a threshold was used, was it pre-specified? Pre-specifying the threshold in a diagnostic study is essential for standardizing interpretation, reducing bias, and maintaining clinical relevance. When researchers set the threshold before looking at the results, they are less likely to change it based on what they find. This helps prevent biased or exaggerated estimates of accuracy. If they choose the threshold after seeing the results, they might pick one that makes the test look really good, even if it is not. By setting the threshold ahead of time, we can avoid this problem and make the study more trustworthy. The third aspect is the reference standard. The reference standard is the benchmark or gold standard against which the index test's accuracy is compared. It is a widely accepted or established method or test that is considered the most reliable for diagnosing the condition. Question 1. Is the reference standard likely to correctly classify the target condition? The reference standard is like a yardstick used to measure how well the index test performs. If there are differences between the reference standard and the index test, we assume it is because the index test made a mistake. But if the reference standard itself isn't accurate or reliable in telling if the condition is present or not, it can mess up the whole study. False positives or false negatives in the reference standard can make the index test's accuracy look better or worse than it really is. That is why it is important to check if the reference standard is good at correctly identifying the condition. A good reference standard should be based on trusted criteria or clear definition that have been thoroughly tested or proven to work. Question 2. Were the reference standard results interpreted without knowledge of the results of the index test? This question is like the one we talked about earlier for the index test. Here, we want to know if the people who looked at the reference standard knew what the index test showed. This is important because knowing the index test results could affect how they interpret the reference standard, and that might make the results biased. Note that if the reference standard is an objective test, like a CT scan or another test that doesn't need personal judgment, the risk of bias is low. That is because the test results do not depend on what the interpreters already know. The fourth aspect focuses on flow and timing of the index test and the reference standard. Flow and timing involve the sequence and timing of performing the index test and the reference standard in the study. It examines how the tests are conducted and the order in which they are performed to ensure accurate results. Question 1. Was there an appropriate interval between index test and reference standard? Ideally, we want to collect the results of the index test and the reference standard at the same time from the same patients. This helps us get the most accurate information, but sometimes there might be a delay between the tests, or the patient might start treatment in between. When this happens, it can affect how we classify the condition. For some conditions that last a long time, a short delay might not be a big problem, but for diseases that change quickly, even a small delay can matter. Also, we need to be careful when tests are done one after another. Some tests have similar parts or can change the results of each other. For example, the slump test and the straight leg test can affect each other's results. So we need to think about when and in what order we do these tests to make sure we get accurate results. Questions 2 and 3. Did all patients receive a reference standard? Did all patients receive the same reference standard? If not all people in the study received the same reference standard test, or if some people didn't get the reference standard at all, it can affect the accuracy of the study. To make sure the results are reliable, it's important everyone gets the same reference standard test. If different reference standards are used, or if the decision to use the reference standard depends on the results of another test, it can introduce bias. For example, if a positive result on the first test leads to a more invasive or accurate reference standard, while a negative result leads to a less accurate reference standard, it can make the test results seem better or worse than they actually are. The decision to use the reference standard should be made before the tests are done and should not depend on the person's condition or the treatments they are receiving. If the decision is influenced by these factors, it can affect the accuracy of the test results. Question 4. Were all patients included in the analysis? It is important to include all the patients who were initially recruited. This helps avoid biases that can occur if some patients are left out of the analysis. If there are differences between the patients who were lost to follow-up and those who stayed in the study, it can affect the results. You can check Table 1 or the result section to see if all patients were included in the analysis. We evaluate the overall risk of bias for a diagnostic accuracy study using the 11 individual questions across the 4 aspects: patient selection, index test, reference standard, and flow and timing. If all the answers to these questions are yes, it means there is a low risk of bias. But if any answer is no, it raises concerns about potential biases. This means there might be limitations in the study design or conduct that could affect the accuracy of the findings. We need to be carefully consider these concerns and their impact on the study results. Sometimes there may not be enough information to make a clear judgment, and that is when we use the unclear response. But we should only use this response when there is not enough data to make a reliable judgment about bias. It is important not to make assumptions or draw conclusions when we do not have all the necessary information. In summary, when we appraise a diagnostic accuracy study, we consider 4 aspects: patient selection, if participants are representative of a larger target population; index test, if the interpretation of the index test without knowledge of reference standard; reference standard, if the reference standard is a valid and reliable examination for the condition of interest; flow and timing, if an appropriate interval between the tests. In addition, if an appropriate statistical analysis is used and appropriate findings are reported. If the study findings can be applied to your clinical setting.